Good morning, and welcome to the CMS 2014 MA and PD Oversight and Enforcement Conference and Webcast. My name is Stacey Plizga, and I am employed by Provider Resources, and I will be your moderator throughout the day. This morning, we are gathered here at CMS Central Office Auditorium in Baltimore, where the webcast is originating from. We are here to accommodate our many subject matter experts who will be contributing their expertise throughout the day. In addition to the participants who are joining us in our audience here, we would also like to welcome our 2,000 plus audience viewers who are viewing the webcast. So welcome to you who are all across the United States. We realize that it is an early hour for many of you, so thank you for joining us for this very important event. Before we get started today, I would like to go over a few logistical items that may help you throughout today. In our efforts to go green, webcast materials are available at the CTO website that is listed on the screen for you. If you have not done so already, you may want to go ahead and download those so that you can follow along with our presenters. We look forward to everyone's participation today. For our virtual participants, should you have a question for a speaker or on a session, please email your question to the email box that is listed on that presentation slide. We will be taking questions from our in-house audience today, and we encourage you to ask questions. Should you have a question, we ask that you step up to the mic that is in the center of the room and ask your question into the microphone. That way, all of our audience members, both in-house and virtual, will be able to hear your question. At the conclusion of this event, we do ask that you give us your feedback by completing an online survey that will be emailed to you upon completion of this event. Your feedback and your opinion are very important to us and help us planning our future events. And finally, if you have technical difficulties, we do have staff members who are available to assist you. An email support mailbox was set up specifically to help you, whether it is an issue with logging in or with the webcast player. Please use the mailbox at CTEO techsupport@cms.hhs.gov for your technical questions or concerns. For webcast viewers, you have the option to enlarge the screen to view the event in full screen mode. By using the arrow that is in the right-hand bottom corner of your screen, you can toggle back and forth. We are glad to have everyone here with us today, both in-house and virtual. We have an agenda that is packed with subject matter experts that will provide insight into how MA and Part D organizations can best prepare for a CMS performance audit. They will also share best practices of high-performance organizations, common findings from audits, and enforcement consequences. With that, let's go ahead and get started. Kicking things off for us this morning, we have the Director for Medicare Parts C&D Oversight and Enforcement Group, Jerry Mulcahy.
All right, good morning. Welcome, everyone. I'm glad to see that compliance is so important to so many organizations. I understand here in the auditorium as our live studio audience, we have about 200 people registered, and as mentioned, there's 2,000 connected via webinar, so this technology sure is amazing. I think this internet thing might really catch on. I just want to say for those on the webinar, you should be grateful that you didn't have to go through security. like the folks who are here. It might actually be easier to get into the White House than it is to get into Medicare. I don't know what it is about Medicare that needs to be so secure, but considering my job as the Director of Audit and Enforcement, I'm comforted to know that I'm safe. So in all seriousness, my group is responsible for the compliance program requirements, the audit strategy and execution, as well as issuing enforcement actions. I want to start off today by telling you about the mission of my group. Our mission is to improve the performance of the industry overall. We operate in a capitated environment. We pay you in advance, and you provide medically necessary covered drugs and services to your Medicare enrollees. The way in which we currently measure the performance of the industry is to test to see if your Medicare enrollees are being inappropriately denied access to drugs and services. Our methods are pretty simple and direct. For Part D, we test rejected prescription drug claims to identify the rejections that were inappropriate. Generally, the inappropriate denials are not malicious. The vast majority of the time, the inappropriate denials are coding and programming errors. We also test coverage determinations, appeals, and grievances. These processes are the backstop of inappropriate denial of drugs, but they also are the backstop for appropriate denials where the enrollee or his or her provider doesn't agree with the decision of the sponsor. For Part C, we test access to care through organizational determinations, appeals, and grievances. These processes serve the same purpose of protecting enrollees from inappropriate denial of services. We also test the compliance infrastructure for form and effectiveness. For special needs plans, we test whether the organization has actually implemented the model of care. As I mentioned, our mission is to improve the performance of the industry overall. To that end, we engage in a variety of activities that are meant to be educational and helpful. We have published the audit protocols, sample documentation requests, 3 best practice and common finding memos, and an annual report. We're about to publish the 4th best practice common finding memo and the 2nd annual report. I really hope that we could have gotten those out before this conference, but it just wasn't possible. We've conducted listening sessions with the industry and surveyed those sponsors who've been audited. We participate in industry conferences, and as of today, we can say that we've even conducted our own focus conference. We do all of this because we actually want to help you to be compliant. Unfortunately, overall, we're not seeing yet the kind of improvement that we had hoped. We started this current cycle of risk-based auditing our way through the industry back in 2010. We have, in the past 4 years, dramatically improved and refined our process. We've fed that info back to the industry so that those who have not yet been audited can learn from those who have. What we're finding is organizations are generally still not proactively testing and identifying ways in which enrollees are being inappropriately denied access to drugs and healthcare services. As I reviewed the draft best practice and common finding memo that we're about to release, we've added a column to show how many times a particular common finding has been in a memo. And for most of these items, it's the 4th time that we've listed it as a common finding. So it's the same issues that we're reporting. So that, to me, says we're telling you what we're seeing out there that's wrong and giving you an opportunity to proactively address those issues, but yet we haven't seen the fruit of that labor. I think the theme you'll hear repeated throughout the day is how to be prepared for a CMS audit. We're not providing this information just so that our job is easier when we conduct the audit, although that's a positive side effect. When we talk about being prepared, it's more about the ability to pull the necessary data, walk us through your system so that we can see what happened in a given transaction, and we're telling you to be prepared so that you know before we arrive, before we send the engagement letter, that your systems and processes and staff are all providing medically necessary covered services at the first opportunity. When we conduct the audits, we're the ones identifying the ways in which your organization is inappropriately denying services. If that's the case, then you've squandered the opportunity to use the tools that we provided to ensure that your organization is compliant ahead of us getting out there. We're also going to talk today, there's a cost to inappropriately denying drugs and services. As you will hear later today, being under sanction or even receiving a civil money penalty has an impact on your reputation, enrollment, and morale, to name a few. Not to mention that several sponsors have been terminated from participation in the program as a result of their performance. We post these actions on our website mainly because the public has a right to know when we exercise this authority given to us by Congress, but also to create a sentinel event for the rest of the industry. We want to help the compliance officers convince their leadership to invest in compliance and performance improvement. This conference offers you all an incredible opportunity to not only hear and learn from CMS about the principles of compliance, program audits, and enforcement work, but also to gain insight which will help you identify possible gaps in your organization's Medicare operations, which may be limiting your ability to be compliant. This state of compliance isn't just a bureaucratic sense of compliance with the term of your contract. This is outcome focused. So did all of your enrollees get the medically necessary and covered drugs or medical services at point of service? I've asked everyone presenting today to allow plenty of time as part of each session for questions and answers. I want to be sure that you leave today with a better understanding of what's expected and how to achieve compliance. Your questions are also informative to us. It gives us a sense of where plans are struggling, where our guidance or direction may be unclear, or in additional ways for us to help you. For example, as a result of the significant number of findings in the areas of organizational and coverage determinations, appeals, and grievances, our appeals group is conducting industry-wide training on these requirements. I want to give a special thanks to the sponsors that are participating in today's panels. I appreciate their willingness to share what they've been through and their practices. In closing, by continuing to work together to achieve improved compliance, we can all better serve our Medicare population and improve their healthcare experience. So thank you again for attending.
Thank you, Mr. Mulcahy, for sharing with us this morning. Our next presenter will be providing an overview of the risk-based approach used to guide audit and oversight, as well as an overview of the analysis of 2013 audit results. Please welcome Kady Flannery.
Good morning. All right, today I will be speaking to you about our 2014 audit strategy and data-driven approach to oversight. During my presentation, I will describe for you our audit policy and strategy, as well as give you an overview of the audit process, which will be discussed in much greater detail later on today. The Part C and D program audits are one way that CMS ensures that sponsors deliver benefits in accordance with the terms of their contracts and benefit packages. Consequently, the program audits are designed to detect instances where sponsors are inappropriately denying services and require sponsors to correct these deficiencies and provide outreach to affected beneficiaries. In 2010, CMS undertook a major redesign of its Part C and Part D audit process, which took us away from audits that focused primarily on processes to audits that focused on outcomes, particularly in enrollees' ability to access needed medications and services or care. Although we have updated the program and the protocols since 2010, any of the updates that we have implemented build upon this original redesign philosophy. Many of the changes focus on continually improving the audit consistency and improving and automating the audit process. For example, we have automated audit tools and reporting functions, and where applicable, we have tried to ensure that protocols consistently test elements as well as test them in the same, excuse me, they're consistent in terms of what is tested and how they are tested. We do utilize feedback from sponsors as well as the auditors, so we ask that given the opportunity that you please provide feedback to us. We want as much information as you're willing to give us, and we are looking for both the good and the bad. For 2014, we will continue to audit the core performance areas. What I'm speaking about here are those areas that have been audited consistently for several years now, with very limited changes to the existing protocols. These areas include Formulary and Benefit Administration, or FA, Part D, Coverage Determination, Appeals and Grievances, or CDAG, Part C, Organization Determination, Appeals and Grievances, or ODAG, and Compliance Program Effectiveness, or CPE. We will also continue to utilize webinar technology, which was introduced in 2012 as the primary means of conducting our audits. As mentioned previously, our protocols continue to be outcomes-based, with a specific emphasis on the performance of core functions and whether or not that performance has produced the desired outcomes for our beneficiaries. In the next several slides, I will highlight for you things that were piloted in 2013 and or that are completely new for 2014. We are keeping compliance in week 2, which was something that was started in 2013. The 2-week approach has lessened the burden for the compliance staff of sponsors. It's also allowed the compliance officers the opportunity to observe more than just the compliance piece of the audit. In addition, it allows more flexibility for CMS and sponsors to conduct a thorough audit review. We've made changes to both the CDAG and ODAG protocols, which I'll discuss on the next slide. And we've introduced standardized conditions, which were also developed in 2013 for each of the audit protocols. To develop these standardized conditions, we looked at the various requirements that were being tested in the protocols and the most commonly identified deficiencies on audit. We then created standardized language to describe these deficiencies. The standardized conditions allow us to more consistently cite the deficiencies across audits, as well as ensure that sponsors are receiving a clear and uniform explanation for their deficiencies. Earlier this year, we posted the 2012 audit scores to our website, and we are also piloting the use of existing electronic transfer systems, which most plans or their third-party vendors are currently employing to submit PDE and/or enrollment data to CMS. We have made changes to the 2014 CDAG and ODAG timeliness protocols based on sponsor and auditor feedback, which is evidence that we do, in fact, take your feedback and try to improve our processes. Many sponsors express their concern for being cited for timeliness based on a targeted sample of cases, especially when their universes demonstrated that in general they were timely. This occurred both during audit as well as during the validation exercises. Starting in 2014, we have made changes to the timeliness metrics for the CDAG and ODAG protocols to a pre-audit universe review. What this means is that auditors will use the universes submitted before the audit to determine the timeliness percentages. Sponsors are reminded that they must exercise diligence in gathering and reporting their universe. CMS will validate samples during the audit to make sure that dates match, and if the universe dates do not match to these selected samples, the sponsor will be asked to resubmit a universe. In such instances, sponsors who have submitted what we consider incorrect data may be referred for a possible civil monetary penalty, or CMP, or other enforcement action. Statute and regulation do not anticipate anything less than 100% timeliness. However, we are not expecting perfection in this area. Therefore, 3 compliance thresholds will be used for these timeliness measures. The first or acceptable threshold will not result in a finding for the timeliness metric, provided that the sponsor's timeliness is above this threshold. The second threshold will result in a finding of non-compliance and will be categorized as a corrective action required, or CAR. The third threshold will result in a finding of non-compliance as well, but will be classified as an immediate corrective action required, or ICAR. Timeliness conditions were never previously considered for ICARs. However, now that we will be testing timeliness at the universe level, we feel that sponsors who fall below this last threshold will have demonstrated timeliness issues so significant as to warrant immediate corrective action. Other things that are different: we have proposed changes to how past performance and star ratings are calculated with respect to the audit results. In 2013, CMS incorporated a new scoring methodology which considers both the number and the severity of conditions found on audit. This new scoring system aligns with our shift in audit philosophy, which now places more of an emphasis on the number of systemic conditions discovered during the audit, rather than the previously used pass-fail thresholds for audit elements. This new methodology allows for differentiation between sponsors who have failed many cases due to a single condition versus sponsors who have failed many cases for many conditions. It also differentiates between sponsors who have failed due to serious beneficiary access issues versus those sponsors who have failed for less significant issues. Also, the scoring system is weighted to ensure that conditions that severely impact beneficiary access will have a greater impact on the overall score. Because this scoring methodology is new, this related star rating measure will be a display measure for at least the first year, beginning with 2015, until CMS ensures that this methodology is sound. Past performance points are generally assigned based on thresholds that target plans that are considered outliers. For audits, this refers to sponsors who have done poorly on audit in general, but also with respect to other audited sponsors. Under the old scoring methodology, any organization who failed 50% or more of their audit elements received a past performance point. Unfortunately, this did not only affect those organizations that were considered as outliers. Under the new methodology, an overall score will be calculated for all sponsors using cumulative data beginning with 2012 for the core program areas of formulary administration, FA, coverage determinations and appeals and grievances, CDAG, organization determination appeals and grievances, ODAG, and compliance program effectiveness, CPE. Those sponsors in the 75th percentile or above, meaning those with the worst or the highest audit scores, will be assessed a past performance point. This change will ensure that only true outliers are impacted. Similar to the past performance analysis, only scores in the 4 core areas will be used to calculate a sponsor's overall audit score for star rating purposes. Again, these 4 core program areas are being used because they have been audited consistently and with very little change to the protocols over the past few years. Depending on the final audit score, a sponsor's star rating score may be reduced up to 50 points, depending from the starting score of 100 points. Thresholds will be determined by an analysis of cumulative data, again beginning with the 2012 audits. We will continue to look at how this methodology impacts the star rating measure to inform decisions about star ratings in the future. Other things to expect for 2014. Audit performance areas related to the beneficiary access to prescription drugs and services will include the Special Needs Plans Model of Care, or SNP Mock, as well as the other 4 core protocol areas that I've already mentioned. Both the 2013 audit results and the annual report will be available on the web this summer. And as Jerry mentioned, we will be making available our 4th best practice and common finding memo. Lieutenant Commander Lorelei Piantedosi will be speaking more on this in the next presentation. Moving on to our audit strategy. Audit results are analyzed each year and compared to our risk assessment methodology to continually refine the process. Program experience has led CMS to include more operational measures into our risk assessment. We believe that these operational metrics align more and have a stronger correlation with performance on audit. This year, we developed an overall risk score for each parent organization based on their audit results, but also utilized existing data to develop program area-specific risk scores for each of the core areas as well as SNP Mock. We will use the 2014 audit results to test the refinement to our methodology as we have done in the past. Ultimately, we hope to develop a truly predictive model that will allow us to target our audit efforts to specific program areas for those sponsors who need it the most based on our results, the results of our analyses. CMS is interested in analyzing audit scores against different measures to look for patterns. That said, we believe a few more years of data will be needed before we can recognize true trends and hopefully towards improvements in performance. Such analyses might be used to target future program areas for audit, to revise or retire existing protocols, or to refine our risk strategy. The next 2 slides are based on 2013 audit data and represents the types of analyses performed on these data. In this slide, we compared the overall average audit score by plan type. And you will note that there are only 2 types listed here, MAPD and PDP. And the reason for this is that we grouped organizations based on where the majority of their enrollment was. So for example, if a sponsor had both MAPD and PDP contracts, but the majority of their enrollment were in PDPs, then they would fall into the PDP bar. As you can see from this analysis, those sponsors with the majority of enrollment in MAPDs did slightly worse than the sponsors with the majority of enrollment in PDPs. In this slide, we compare the average overall audit score by the tax status. And again, as you can see, those with the nonprofit organizations did slightly better than their for-profit competitors. For the remainder of the presentation, I will provide you with a brief overview of the audit process. In preparing for a CMS audit, we recommend that you identify your audit team and use our protocols to make sure that you can appropriately pull universes. It is critical that sponsors correctly compile their universes and submit them by the stated deadlines. To the extent possible, we also recommend that you test webinar technology and test your operations using our protocols prior to the audit. There are 4 stages of the audit. During the first stage, CMS will issue an audit engagement letter for 4 weeks prior to the audit for routine audits. We will then hold a follow-up call with sponsors within 2 days from the engagement letter, and sponsors are expected to submit their universes within 10 days of receiving that letter. 2 weeks before the audit, CMS will send a draft audit report and will conduct analyses of the universes received from the sponsors. Finally, CMS will select samples and provide them to the sponsors either the day of the audit for FA, CDAG, and ODAG, 2 business days before the audit for CPE, and 3 business days before the audit for SNP Mock. As noted previously, the audit occurs over a 2-week period via webinar technology. During the first week, we will conduct the operational audit simultaneously for FA, CDAG, ODAG, and SNP-Mock as applicable. Although these are conducted by webinar, CMS may send a representative on site either the first or second week of any audit. At the beginning of the week, we will hold an entrance conference. We will then conduct the audit and provide sponsors with a written draft summary of the findings. At the end of the week, we will hold a preliminary exit conference. We do encourage sponsors to begin correcting any deficiencies that were noted during the audit. During week 2, we will conduct the compliance portion of the audit. And at the end of the second week, we will hold a final exit conference, which will cover the entire audit. Stage 3 is the post-audit period, which the team leads will approve the audit documents, and CMS will issue the draft report within 60 days of conducting the audit. The sponsor will then have 10 days to review this draft and to submit comments. It's worth noting that even if you do not have comments to the draft report, you are still required to communicate this via HPMS. The final report will be issued within 10 business days of receipt of comments, or in some cases, no comments from the sponsors via HPMS. Finally, during stage 4, which is the corrective action and validation stage of the audit, sponsors will be required to submit their corrective action plans for all CARs and ICARs. For corrective actions, for CARs, corrective action plans are due from the sponsor within 7 days of the final report issuance. Once CMS accepts this plan, sponsors will be given 90 days to correct the findings noted in the final report and conduct internal testing to validate the effectiveness of the corrective action. Regional offices will lead the CAR validations to ensure that corrections are in place and have addressed the issues found on audit. For ICARs, corrective action plans are due within 72 hours of CMS notifying the sponsor about the ICARs. Once the corrective action plan is accepted, CMS will contact the sponsor about the status of the corrections, and the validations for the ICARs will be done at the same time as the CARs, which are, again, performed by the regional offices. If the findings are corrected, CMS will close the audit. If findings are not corrected, CMS will consider additional actions, including CMPs or other enforcement actions. This concludes my presentation. You may submit any inquiries related to audit policy or strategy to the mailbox address shown on the slide. I thank you again for your time, and I'm happy to take any questions. Seeing none, I wondered if there was anybody in the audience who was brave enough to talk to us about things that they haven't seen out published from CMS or out in guidance that perhaps they would like to see, or any recommendations for improving the process, conducting our analyses. No? Okay. Well, thank you again.
Okay, thank you, Kady, for sharing with us this morning. In consideration of our many webcast viewers, we are going to adhere to the schedule that is in the agenda and the session times on the agenda. So we are a little bit ahead of schedule right now, so we are going to take a break, and we will reconvene at 10:30, at which time we will hear from Lorelei Piantedosi. So feel free to stretch your legs, and those of you in our viewing audience, you do the same, and we'll see you back here at 10:30. Thank you.